alaikum wa rahmatullahi wa barakatuh. Today I'm going to discuss a case series was published earlier in July of this year to 2026. It was titled Differential Healing Pattern of Odontogenic Maxillary Sinusitis Following a Non-Surgical Endodontic Therapy. Going to their inclusion criteria, it was a non-vital teeth or previously treated teeth presenting with apical periodontitis, and for the diagnosis was confirmed by pulp sensibility testing and radiographic examination, and also a confirmed diagnosis of the maxillary sinusitis of dental origin, radiographically linked to the affected tooth. And the final criteria, it was including 10 patients, ages 25 to 41, with OMS secondary to diverse endodontic causes, including dental caries, missed root canals, and cracked tooth syndrome. For their materials and methods, all treatment were performed under a dental operating microscope with rubber dam isolation following local anesthesia. Canals were instrumented with the rotary night eye system, and in retreatment cases, prior filling was removed with retreatment files and solvents. Irrigation combined with 1% sodium hypochlorite, 17% EDTA, supplemented with ER-YAG laser activated irrigation for the enhanced disinfection, calcium hydroxide for minimum of 2 weeks placement, and a systemic antibiotic were prescribed for only one patient for case number 2, a 3D course due to the severe presenting symptoms, and the canal were subsequently obturated using warm vertical compaction with single cone technique with bioceramic sealer, and teeth were restored using a resin composite or a full coverage crown. For the follow-up, CBCT was obtained at 3 months to assist early healing, with additional imaging at 6 to 17 months. Imaging used a standardized protocol, and two calibrated endodontists independently evaluated all scans using the Planmeca Romexis software. For the outcome measures, success was defined as absence of the clinical symptoms combined with radiographic evidence of healing, and preapical bone destruction was scored from 0 to 5 using the CBCT PAI index based on the largest lesion dimension across the three imaging planes. For the maxillary sinus mucosal thickness was measured on a coronal slices perpendicular to the sinus floor with less than 2 mm defined as the normal physiological threshold. Going to the classification of the cases based on the relationship between the periapical and the sinus lesions, the 10 cases were stratified into the four radiographic pattern. So for pattern A, which was cases 1 and 2, periapical bone destruction with maxillary sinus floor perforation. Pattern B, which is cases 3 and 4, periapical bone destruction with an intact sinus floor. And for pattern C, which is half of the cases 5, 6, 7, and 8, and 9, minimal and no periapical bone destruction, apex approximates or protruded into the sinus. And the last category, pattern D, which is the preapical osteoperiodontitis, which is the halo lesion for the last case number 10. For going into details in these patterns, for pattern A cases 1 and 2, both presented with a chronic apical periodontitis complicated by directed perforation of the maxillary sinus floor. Preoperative CBCT showed cortical discontinuity with extensive sinus opacification. Preapical radiographs correspondingly showed a disruption of the sinus floor, a white line, and for case 1, the retreatment healed comparatively more slowly than the case 2, which was a primary treatment. Both achieved the reestablishment of the sinus floor continuity and mucosal normalization within 3 to 6 months on both imaging modalities. For pattern B, which were cases 3 and 4, both were retreatment cases involving symptomatic apical periodontitis following inadequate prior endodontic therapy, in which extensive bone destruction was only faintly visible on the periapical radiograph. CBCT demonstrated a clear temporal discrepancy, a sinus opacification resolved to normal within approximately 3 months in both cases, while osseous regeneration took approximately required 17 months for the complete bone healing, the longest interval in the series. And for case 4, similarly showed a resolved sinusitis at 3 months, and despite of the incomplete bone healing. For the pattern C, which is the largest subgroup with heterogeneous etiologies, for case 5, it was a multi-tooth involvement after crown placement. Case 6, deep caries. Case 7, rhizome-filled deep caries and hidden caries with calcified MB2 canal in case 8, and case 9 with a cracked tooth syndrome. In all 5 cases, root APCs abutted or protruded into the sinus, permitting diffusion of the inflammatory mediator through the porous bone despite the minimal bone destruction. PAI score 0 to 1, and pre-apical radiographs offers a limited diagnostic value here. For that, CBCT was necessary to identify and monitor opacification, which resolved within the 3 months in every case. For the last pattern, pattern D, which was case 10, this single case demonstrated preapical osteoperostitis, in which inflammatory exudate elevated in the intact sinus periosteum, producing a radio-opaque or halo obscured on the preapical film by superimposition. Complete radiographic healing was not confirmed until 17 months, though a reduction in the elevated sinus contour was already evident on CBCT at 3 months. To conclude the outcomes across all the 10 cases, 100% achieved resolution of the clinical symptoms and radiographic resolution of the sinus opacification. Sinus mucosal lesions, including perforation cases, normalized to less than 2 mm thickness within approximately 3 months. Preapical bone, alveolar bone regeneration required longer, more variable interval of 3 to 17 months. Cases with extensive bone destruction or periosteal displacement showed the most delayed bone healing. To conclude, that maxillary sinus mucosa consistently healed faster than preapical alveolar bone following non-surgical root canal therapy, typically normalizing within 3 months, irrespective of the initial bone destruction severity. A preapical radiograph remains adequate for monitoring overt perforation or bone defects for pattern A and B, as we saw. But CPCT provides superior diagnostic value in anatomic complex presentation, particularly patterns of C and D, where preapical films are frequently inconclusive, and the early mucosal resolution on CBCT at approximately 3 months is proposed as an adjunctive early indicator of favorable treatment response, while preapical bone regeneration is acknowledged to often require substantially longer follow-up. In my opinion, the limitation of this case series study, the absence of the control group as it is a case series and a small sample size, and the variable sometimes short follow-up interval precluding a definitive conclusion on the long-term or longer-term osseous regeneration, as well as the proposed prognostic value of early mucosal healing is presented as preliminary hypothesis requiring a validation in a larger perspective standardized cohort before the clinical adaptation. And thank you.